Hey guys, if you haven't heard about Anchor by Spotify, it's simply the easiest way to make a podcast. Anchor by Spotify has everything you need all in one place. So let me explain. Now, Anchor has tools that allow you to record and edit your podcast right from your own cell phone or your own computer. Now, I've been using and loving Anchor by Spotify for 2 years now. And don't forget that Anchor will go ahead and distribute your podcast on so many listening platforms like Spotify and Apple Podcasts, and so many, many more. Now, I think it's simply everything you need to make your own podcast, all in one place. And don't forget, Anchor is totally free. So why don't you go ahead and download the Anchor app or go to anchor.fm to get started. I can't wait to hear all of your podcasts. Hey everyone, welcome back to all my listeners. If it's your first time finding me, thanks so much and welcome. Come on in, you guys. This is episode 16 of my 7th season. Today is Wednesday, December 21st, 2022. My name is Sonal Patel, and this is the Paint the Medical Picture podcast series. All right, kids, there's just a few days left until Christmas. It's the 3rd day of Hanukkah. It's crunch time to get those gifts and finally spend quality time with who you want, friends, family, colleagues, and peers. Just unwind and celebrate all the goodness 2022 has given you. And of course, it's also time to pen all your wishes and wants for 2023, right? So go ahead and pull out those vision boards, start journaling, write down those thoughts, those possibilities you want in 2023. The new year has so much in store for us. I'm certain of it. Now, anyways, you guys, let's start diving into my show today. I want to be diving into my compliance tips and my compliance recommendations today on new coding and billing for home services starting January 1, 2023. That's just a couple of days away. Now, also in my final red carpet of season 7, I'm rolling it out once again for my very special return newsworthy guest, Glenn Krauss. And of course, I round out today's episode with a remarkable quote on purpose and impact by Leonardo Da Vinci. If you've checked me out on LinkedIn, you know I'm all about compliance and protecting our physicians and valued healthcare professionals when it comes to the business of medicine. I hope this week with me brings you enough to take back to your organizations, to want to dive in deeper, to use my tips and best practices to ensure success. I hope this podcast will help you boost the quality of documentation capture and improve coding accuracy as you help all of your providers paint the medical picture. If you like what you're hearing, please go ahead and hit that subscribe button now so you don't miss another episode. Please write in a review and kindly drop me a 5-star rating on Apple Podcasts or wherever you listen to my podcast. I'd really love your support. And as always, a friendly disclaimer. Remember, I'm bringing you the news, current healthcare industry news, my compliance tips and my compliance recommendations based on my over 12 years of experience in front office, in back end, in coding, and in billing for multi-specialty physicians, in compliance, and in auditing for both E&M and surgical operative reports. These are my opinions alone and are not to be construed as legal advice. So, let's get into a very special newsworthy, and it features my very fabulous return guest, Glenn Krauss. I'm so excited to see you here, Glenn. Welcome. Welcome back to the podcast.
Yeah.
Now, you know what? You wanted to come on the podcast today to go over this OIG report.
Right.
I really am excited for us to dig in and unpack just what the heck is going on, right? Because before we hit the record button here, we were talking about this, ever climbing, this upward, quote unquote, trend toward more expensive inpatient hospital stays in Medicare emerged before COVID-19 and warrants further scrutiny. Now, that's the title of this OIG report. And like you and I were talking off the air here, these types of reports are just growing right? Bigger and bigger.
That's right.
Year after year. And this particular one, I want you to really unpack for my audience, just give us a quick synopsis of this alleged upcoding of not CPT codes that I've talked on my podcast before, but upcoding of diagnoses to be more severe than actually what the validated documentation reflects. So I really want you to help my audience understand in terms of what does upcoding of diagnoses mean and what types of codes are there?
Okay, great questions. First, thanks again for having me on the podcast. I really enjoyed speaking with you. So Absolutely. Here's the situation. Whenever I say upcoding, when I see upcoding, I think of back in the one was in the 90s with the upcoding of pneumonias. Remember that?
Of course.
Okay, this is a little different to me. I don't see it as intentional upcoding. I'm a coder by trade. You code as well. Yes. We don't sit there and make up diagnoses and code jam. We just don't do that. We have a code of ethics. We got an EHEMA code of ethics. That's right. So whenever I see upcoding in the OIG reports, more recent, this most recent one came out in February of 2021. I take a different viewpoint of upcoding. Okay, I believe having still been in the charts, having been in the charts, in the thick of things, is to me over what I call over or up documentation. Okay. Over documentation.
Oh, okay.
And so coders are in. Well, we're sort of in a quandary here because our coding guidelines from what 2016 coding was it 2016 coding clinic I think stated that we're not supposed to we are not allowed to question the doctor's clinical judgment and medical decision making. That's why they went to medical school, residency. Some people went to fellowships.
That's right.
And I respect physicians because most of my colleagues or friends are physicians.
Right.
And so we're not supposed to question the diagnosis. And then they clarified in the coding clinic, last quarter, I think this year, prior quarters, that they said if there's any conflicting information in the chart, ambiguous, was supposed to query for the physician to clarify the diagnosis. Okay. Right. And so if we have it in the chart, it's clearly documented in the chart, we're stuck. We have to code it. And so here comes the OIG or the payers saying this is upcoded. Well, they don't say upcoded. They say we disagree with this diagnosis on a basis of clinical validation. And they give you, and I've seen letters that say, just last month, I've seen letters from the payers, commercial payers, that say, despite the fact that the diagnosis was throughout the record in the discharge summary, nevertheless, we disagree for the following reasons. Okay, and so that's they're in essence calling that upcoding. It's in the chart, but we don't see the clinical picture of that. Therefore, we don't want to pay. So that's what I think. What is upcoding? It's not intentional. We made up the diagnosis. It's in the chart. And the question, I think it beckons the question of whether the doctors are. I don't think doctors are intentionally over documenting. No doctor gets out of bed to say, "Let me see how much over documentation I can do today."
Right.
Are you thinking the same?
Right. No, absolutely. When you gave me this report and I reread it because I did see it the first time in 2021 as well. But I wanted to reread it for our conversation today. And it really upset me. Absolutely. It upset me because the light that the OIG is, spinning on doctors and hospitals in this entire report is troubling, because I agree with you. I do not believe that our coders just go around and misidentify codes and upcode things. And I most certainly do not believe that our doctors in the hospital settings are going around documenting things that are absolutely wrong, absolutely not painting a clear medical picture of the patient, right? So
Yeah.
I was very disturbed when I read this report.
And me too, but one thing I think that's important to know is that when I review records, I work with a couple of doctors, Dr. Jake Martin for 27 years and Dr. Doug Cutler, who's still practicing. He's still a hospitalist. Okay, so he's been a physician advisor and a medical director. And yesterday we were talking to a client as a part of our clinical validation review, and he brought up an interesting point, which I've been saying for years. Okay, he was talking to a hospitalist on the other end who was invited to the meeting, okay, with the revenue cycle director, is that it's not that the diagnosis, it's not upcoding, it's that the diagnosis is not supported by the doctor's clinical. Do you remember the coding clinic says we're not supposed to question the doctor's clinical judgment and medical decision making? The limitation that we have, I think, in terms of over upcoding or over documentation is the physician is not explaining,
right?
They're not documenting their clinical judgment and medical decision. Dr. Martin says it ain't so just because the doctor said it's so. It used to be way back when we first went into coding in the early 90s. If the doctor said it, the payer agreed. Okay, if the acute respiratory failure, patients got that. But now, as time has gone on, they, in the interest of not wanting to pay, they question a lot of the diagnosis. And why are they winning? Because the doctor doesn't give us his indication of what led them to believe that this diagnosis is what I came up with. You just can't write it in the chart and say, okay, I'm done with my assessment and plan. That's the biggest limitation of documentation that we're not addressing in CDI programs.
I agree with that. Absolutely. It is all about, making that medical documentation more clear to support, how our coders can then, use their coding instructions, use their coding guidelines to support those diagnoses that the physician is seeing in the patient while they're in the bed, right, for those 3 to 5 days. Now, let's go back to our report, right? So this particular report also gave me pause, and I really need you to help unpack this for me because
I'll try.
Yeah. You're the expert here. So, this particular report really honed in on highest severity level diagnosis codes that were used for a particularly short amount of time, which means that the patients were not considered inpatient for too long, right? They were kicked out, they were discharged, they went home safe and sound. So that's how I read that OIG report. So it's like they're sort of saying these patients were found to be really sick with the highest severity level for either COPD, which you can explain to my audience what that is, or they had heart attacks, things like that you can talk about, right? But then they were taken care of, right, with advanced medicine today in 2022, right? They were taken care of very well, and they were able to be discharged. So can you sort of address that kind of issue that I see in this report? The OIG is kind of upset that the doctors and the hospitals took such good care of these patients with these highly severe diagnoses, right? But then they had to be reimbursed at this high severity level as well, right? Yeah.
So let's take a sepsis, for instance.
Okay.
A lot of sepsis is usually one of the top 3 or 4 DRGs in a hospital's top 20 DRGs. And I think sepsis is certainly being over-documented, over-diagnosed. So you may have a patient that's I read a blog the other day, a physician blog that said that maybe oftentimes or sometimes we're prophylactically treating the patient to prevent sepsis, but they write sepsis down, okay? You look at the medical record, you don't see a sick patient. Sepsis is supposed to be a sick patient with change in mental status, elevated white count, some type of organ failure. If you see documentation like I see, sepsis with metabolic encephalopathy, or a UTI, a lower urinary tract, partially treated UTI, severe with metabolic encephalopathy, documented, and you read the record and it says the patient's alert only times 3, sitting on the edge of the bed, just finished polishing off a cheeseburger and fries. Okay, I'm not making it up. That's what I saw. The payer didn't want to pay for sepsis. Well, do you blame them? No.
No.
2 day. I'm seeing sepsis with 2 days stay. They come in and they go home. Okay, don't have. So that's a red flag. Short length of stay, like the OIG says. When you look at the chart,
when you look at the chart, yeah,
they're not looking at the chart, but I'm looking at the chart,
right?
And so I think there's a parallel. I obviously have reviewed hundreds of charts this year as part of clinical validation, CDI assessment programs, and I'm seeing diagnoses being documented with that are not supported by the clinical facts or information. Maybe the indicators are there, but really, what's missing is a clinical portrayal of the patient. Another example I think that comes to mind is if I see pneumonia and I don't see a sick patient, the lungs maybe have a little wheezing because they have COPD, but they're not in exacerbation, or maybe they're in early exacerbation. And when I document pneumonia, exacerbation of COPD, aggravated by infectious process of pneumonia, but there's no white count. There's the X-ray doesn't show any infiltrate. Now maybe the patient has early pneumonia, or they have maybe if they're in Texas in the middle of the summer, in Houston outside or somewhere hot, and they're working in the garden, and obviously elderly people don't have the same thirst drive, and they're a little bit dry. So when I see an X-ray, I don't see the pneumonia. I hydrate the patient. But doctors don't say anything about, despite the negative chest X-ray, still think the patient has pneumonia because of X, Y, and Z. That's not in the chart. So what happens? The pneumonia gets questioned as upcoding, but the doctor wrote pneumonia. But because it's not clinically supported, the payers are saying that's upcoding.
Wow. You've explained that for my audience so well with your specific examples, Glenn, that you've seen over your work.
That's right.
In the years. So I totally appreciate that. Appreciate that.
Yeah, thanks.
Now, so you know what? So what this report is highlighting, right, is that there are at least over 2 million of these types of short stay claims that they believe have more than likely been overpaid, right? Based on these hypotheticals that you happened to mention, right? That these types of short stays for a high severe diagnosis level, right, may not actually be supported when they're actually looking at medical records.
Right.
So I totally appreciate that. But I also want you to help me help my audience understand better, right, what the IPPS system is, right? How is that inpatient prospective payment system actually set up? Because, you know, at various points in this OIG report, I thought I had read pretty clearly that the MSDRG rate is already set, right? They're already going to be paying it, right, at the highest level of severity, regardless of how long the patient is staying in the inpatient setting for, right?
That's right.
Okay.
So if you let's say I'm looking at someone's data, top 20 DRGs. Let me go over here. Okay. So I have. I'm just going to read a couple so I can explain.
Please.
So their number one DRG was sepsis, 871 and 872. Okay.
Okay.
Second one was DRG 291 through 293, heart failure and shock. And let me see here. The third was complex pneumonia, Klebsiella pneumonia, COVID pneumonia, Staph aureus pneumonia, E. coli, okay, MRSA pneumonia, 177 through 179. So depending, so if I have, let's say E. coli or Klebsiella pneumonia, and then the doctor says Klebsiella number 1, they come in with shortness of breath, lethargy, dyspnea on exertion, weak, okay, white count of 23, temperature 102, respiratory rate of, let's say, 24, heart rate 120, definitely tachycardia there. Okay?
Yeah.
So I'm going to code that as let's say, Klebsiella pneumonia with acute on chronic respiratory failure, hypoxemia, PO2 of let's say 50, and the member of the 50-50 club, and then the CO2 is 60. Okay, so I'm going to code acute on chronic hypoxemic respiratory failure as a secondary. What occasioned the admission was Klebsiella pneumonia. So that would group to a DRG 177. Okay, respiratory infection and inflammation with major CC. The average length of stay is 5.7 days. Now, that's an average.
Average.
Okay. Now, let's say they went home in 2 days or 2.5 days. Right. Well, that could be that raises a red flag for payers and the OIG because they're seeing shorter length of stay. If a patient truly had acute on chronic respiratory failure in the setting of a Klebsiella pneumonia, they wouldn't necessarily, unless they died in the hospital, they wouldn't be going home in 2 days or 2.5 days. So I think that so they get the same payment for the 2.5 days as they would if the patient spent the average length of stay of 5.7 days. Okay, and so that's why they call it prospective payment. So the hospital is getting paid for a more sick patient because they have that acute on chronic respiratory failure. I think what the OIG is saying is, hey, wait a minute, we're paying hospitals, or the hospitals are billing highest level DRGs with 1 major CC, and more than 50% of the time, 50%, more than 50%, or almost 50% of the amount spent every year was attributable to these high-weighted DRGs. Okay, so that's why they're saying that we have some concern, because more than half of what we're spending expenditures for inpatient throughout the country are attributable to these high-risk DRGs, meaning 1 major CC. And they did point out that their concern was a good majority of the high-weighted DRGs had only 1 major CC. So that's questionable. They're saying that they didn't look at charts, but they're saying this could be a problem that needs to be evaluated more in depth by the CMS.
Okay, so how on earth did CMS address this OIG report then? Did they agree with these findings, or did they present some pushback?
No, I think if you read the report, what I just did before we came on the air, they say that thank you very much. Basically, what they said was from Summer Verma, the previous CMS administrator, Medicaid administrator, said thank you very much for the report. We appreciate your work, but we have a different take on this. They're saying that because they didn't review the charts, they don't necessarily agree with all the findings, and they were I think in an effort to push back a little bit, they were discussing, or they're saying that they have a robust program in place for reviews, integrity. They have the RACs and they have the MACs, and they have sophisticated data analytics and data mining. They sure do. Okay.
Yes, they do. Yeah.
And they have a CERT program as well. But they're saying that because they didn't look at charts,
They did not. Yep.
These changes could be attributable to other mitigating factors, such as the fact that we have advances in medicine. They even mentioned the fact that we have new, more specific codes with ICD-10. Yes, we do.
Yep.
Okay, but medicine has not changed. The diagnoses have not changed. They may be in a different code. Okay, but the number of major CCs is dropping every year, pretty much. The trainers are not adding; they're taking away.
They're taking away.
And
True.
also, it says that there's a nationwide expansion of clinical. I'm going to read this sentence here.
Please.
It says, improvements of coding software have promoted coding sophistication in recent years to accommodate the new diagnosis classification introduced by ICD-10. And then in conjunction with that, they had led to the nationwide expansion of CDI, or clinical document that utilize medical record documentation review to ensure that all relevant conditions throughout the patient's hospitalization are accurately captured in the medical records. CMS remains committed to supporting significant advancements in biomedicine that are changing healthcare delivery for the better, as new technologies can increase efficiency. What they're saying, patient can get home in a more expedient fashion by promoting cost-effective care, improving outcomes. And I agree. However, on the other hand, I want to throw this out there for discussion, for your audience to think about. Okay, if you think about medicine, medicine has not dramatically changed from 2014 to what? To the 2019? That's right. That's the study report. We've had new drugs. We have a real advancement of new procedures. But if you look at the DRGs they're referencing, they're not surgical DRGs.
They are not surgical.
They're medical DRGs. Okay, and people, yes, they're coming in sicker. Okay, but I want to play devil's advocate. Now that we have CDI specialists and we are incentivized, or our performance is measured based on number of charts reviewed, number of queries issued, number of CC-MCC captures, changes. What is our capture rate for CCs and MCCs? What is the agreement rate? What is the congruence between the coder and CDI? Whenever you focus on reimbursement, there is the danger. There is to me, is elevated danger or a situation. I'm not saying it's intentional to increase our case mix index as the ultimate measure of CDI, and if we're being measured by processes that change the diagnosis or add diagnosis, there has to be a certain level of compliance that goes with that. And sometimes we get over aggressive. Sometimes we don't have the strong clinical picture. We may have indicators. On the other hand, the clinical rationale, thought processes, judgment, analytical a mindset that the physicians go through in coming up with diagnosis, that's not captured. And so I did a piece on ICD-10 monitor. I'm sure you saw it on Tuesday. I said naked diagnosis. It's like a mirage. We have a diagnosis, but there's no clothes on. We're in the desert. We look like we got water, but there ain't no water. And so the payers are having a field day. I see it myself personally, my doctors I work with. And so I agree with in essence, in summary, I agree with the fact or the statement that the OIG did not review charts. But there's no doubt in my mind, if they did, that we would have a situation where we could validate upcoding, not from the coding perspective per se. It's because we have documentation that's naked. We have diagnoses that are naked.
Glenn.
Yeah.
Profound.
Does that make
sense?
Mean,
oh my God, your last few statements in there are just nuggets for me and my audience to replay in our minds again and again.
And if you look here, just to reiterate, I want your audience to hear this, okay? This is a hospital. I'm going to look let me see. Oh, it logged me out. Why did they do that? Don't you hate when it logs you out?
I hate when they quickly log you out.
Yeah. I mean, one time I was looking at a big chart. I knew what page I on. It logged me out because I I went to get a drink of water. I
You
come
got
back,
a sip of water.
and
5
I
minutes.
know I forgot to find out what page I'm on again.
Yep.
Hold on, hang
on. I know.
I'm gonna. This takes me 1 second to log in here, so I think this would be quite helpful. Okay, here we go. Now I see this. Pretty fluently or quite commonly.
Mm-hmm.
I'm going to look at the top 20 diagnoses. Okay. Now I'm going to read you that. Not all top 20. I'm going to read the top 5 or 6. Okay. Acute kidney failure. This is a 30-bed hospital with what did I say? 32-bed hospital with 729 discharges in fiscal year 2021. So I'm going to look here at my top 20 diagnoses, focusing on my top 5. Okay, they had 740 discharges. They had 140 discharges with a secondary diagnosis of acute kidney failure, with 17 as principal. Then we had hypernatremia, 104 cases secondary, 15 principal. Then we had COVID-19, 103 principal, 13 as secondary. I'm okay with that. Then we had hypertensive heart and chronic kidney disease with heart failure in stage 1 through 4, unspecified chronic kidney disease. Okay, that's a CC. All right, they had, let's see here, they had 13, they had, 85 cases, secondary 25. Then they had UTI, they had UTI as a secondary. They had 87 cases of secondary. Oh, and one more, this is 6. They had 62 cases of pneumonia as secondaries with 22 cases as principal. Now, and I can go down the list, 3/4 of the diagnoses that were in the top 20, they're all CCs or major CC. For instance, they had 98 cases of acute blood loss anemia. Well, I can tell you without even looking at the first page with the top 20 diagnoses, DRGs, that GI hemorrhage is going to be in the top 10, and it sure was. They had 16 cases with 100% CC-MCC capture rate. Okay, so we know what the CC is. It's acute blood loss anemia, and I'm finding that a lot of cases I'm looking at, it didn't extend the length of stay. There was no monitoring, or maybe there was monitoring. There was no transfusion, which doesn't mean it could not be acute blood loss anemia. But I can see where the payers are having a field day because we're maybe over querying, and I have seen some doctors tell me personally, I'm tired of queries. So what are you doing about them? I'm putting down a diagnosis prophylactically so I don't get a query.
Oh, wow.
And people laugh, but I've heard that from more than one physician.
Oh, wow.
Probably 10 or 15 in the last month. I say, we're getting tired of queries. What are you doing? Not answering? No, I'm answering. I put down the diagnosis because I think I'm going to get a query. That's a dangerous situation.
That's dangerous. Yes. I don't like that.
I'm not making this up. I've heard it from practicing physicians.
I don't like that.
So when I see the situation where I have a high number of diagnosis in my top 20, they're all CCs or major CCs, it beckons the question, are they supported in the chart? Or when I see 100% CC-MCC capture, I mean, that's not a couple of my math major colleagues in college, I reach out and say, that's not statistically possible. It's not clinically possible. Doctors tell me to have 100 or 268 cases of a heart failure, and then we have 100% CC-MCC. I just don't see it. It's just out of control, and I feel bad for coders because we're kind of stuck in the middle. We're getting a bad name. We're saying we're upcoding.
Totally.
We ain't upcoding. We don't get up in the morning to say, "Oh, we don't get paid. We don't get paid more money to capture major CCs. We still get the same hourly wage."
Exactly. No, yeah. And that was the bottom line for these types of reports, right? That is my primary thought here, right? Is that it's just kind of a bombastic statement to put out there, the term upcoding.
It's like, no. Up documentation.
It's up documentation.
I call it, I have a slide I made. I put it on this, I put it up there to the physicians. It's called hyper documentation. It's like,
Yes.
this is
That
not.
should be a term. Absolutely.
Yeah,
That should go in the dictionary. Yes.
there should be ICD-10 code for that
There
to
should
tell
be an
them.
ICD-11
The
code for
other
that.
thing is
Yep.
that, it's not, I think, up documentation. It's under documentation.
It's under
The
documentation.
clinical judgment. And
Yes.
unfortunately, I hate to say this, but I'm going to have to say it. I've said it all the time. I'm not making a lot of friends, but CDI, we haven't focused on that piece that we really should be focusing on. It's the clinical judgment and medical decision making that physicians, and they're looking for help. Physicians want to do right. They want to help their patients.
Of course they do.
And they're looking for tools. They're looking for tools that they can put in their toolbox to help communicate more effectively. They don't
Exactly.
Physicians sometimes tell me, just tell me what to write and I'll write it. No, we can't do that.
We can't do that for you.
Excuse me, doctor, can you help me out? Clarify. Just tell me what to write. I don't want these queries. And that's another podcast in itself. Queries.
That's another whole podcast. Yeah,
we can be on for 4 hours on that.
At least 6 hours, in my opinion. Yeah.
So there, I think I want to say, just in summary,
please.
It's not upcoding. It's not. That kind of puts a negative limelight on our profession. I'm a coder by trade. I still code. I don't get up in the morning and come downstairs to my office and say, okay, here we go. We're going to do about 20 cases of upcoding. No.
Exactly.
Yeah.
Right. No, we don't do that.
And if we have to query every physician for something that may not be well documented, but the diagnosis is there, but the clinical indicators specific, not just the clinical indicators in the chart, they have to be acknowledged. And that's going to be important in 2023. I'm still reading the E&M new guidelines for inpatient and observation, just like the same they were for outpatient.
Right.
And the amount and complexity of data to be reviewed,
yes,
analyzed, and interpreted. You cannot just have the labs in the chart and expect that and get credit for reviewing them when you don't comment on them. You're gonna have to put your clinical significance as part of your diagnosis process. Aspiration pneumonia in a high-risk patient with Alzheimer's and dysphagia from a sequela of a stroke. If you don't put that in there, the payer is going to say, well, there's no aspiration pneumonia. There's no risk factors. There was no witness. I've seen them say there's no witnessed aspiration. There's no clinical risk factors documented. Therefore, we're going to make it a simple pneumonia. And then they save themselves, if they're a commercial payer, about $12,000 by doing that. And how can you defend that? We're stuck. We have to code aspiration pneumonia. We can't go back to every physician and say, doctor, can you tell us how you came up with the aspiration? We would have no charts. We would have a discharge not final bill, and our coding director, our manager, would be down there, not our friend with the whips. Hey, come on, what is this?
Right, those whips would be never ending.
Yeah.
Oh my goodness, Glenn. Yes, you are absolutely right. We are pro coder. We are pro CDI. We are pro active in our education efforts together on all fronts, inpatient front, outpatient front, everywhere. Your insights today on this particular OIG report really got you and I both thinking, right? We were both playing the devil's advocate, both sides of the fence throughout the conversation, off air and on air. Wow. I'm going to have you back on again too. You just brought up something really interesting that I know is going to cause significant hiccups for the inpatient side on those new E&M guidelines for all of you on the inpatient setting. I see a lot of issues coming up, and you hinted at that for the data points in terms of your laboratory reviews and discussions and things like that. We need to see that in the documentation. So yeah, you and I can have another big conversation on those requirements as well.
I really appreciate the opportunity to be on here, because people, when I see, like I said, upcoding, I said, no. Then I reached out to you and said, no, we're not upcoding.
No, exactly. We are
but,
not.
But,
nope.
It just appears so because they have to point the finger at someone, and they ain't going to point the finger at a doctor.
Heck no. No, I know. It's
Doctor,
amazing.
Are you up, doctor? We have a epidemic out there. We got hyper documentation in all of the hospitals. No, physicians will have a mutiny if they saw that.
I'm telling you, but these reports just get more and more scary with less and less documentation actually being reviewed. Like you and I actually review the documentation.
Yes. I only have a few pieces of hair left. I need to go to that haircut. I live in a small town, and every time you go over there, the guy says, well, I'm closing now. I say, your sign says you're open till 5. Well, I don't feel like working today. So I'd pull out all my hair because it's just getting to be very frustrating.
Absolutely really frustrating. But I'm going to end with a positive note that you and I are both champions for coders, and we are champions for CDI. And we're champions for the inpatient, outpatient settings. We love our doctors. Absolutely. We are positive people.
Glenn, we want to make a change. We want to change.
We want a change to happen. Oh, absolutely. Yeah. I support your endeavors. I'll do whatever I can to help you get the right tools in place for the inpatient setting to make CDI improvement actually happen, right? We're all about making change happen, right? It might be a little slow, but we definitely are all about it, 100%.
One sentence. It's really all about proactive, preemptive denials avoidance. Dr. Martin came up with that concept, and I've been trying to promote it. It's proactive, preemptive denials avoidance. It's not a preemptive diagnosis so you don't get a query. It's proactive, preemptive denials avoidance through far better documentation, and specifically in my history of present illness, which is going to be crucial now, even more crucial under the new guidelines of E&M for if you bill based on time for medical necessity, and also for clinical judgment. So there you have it. Another great podcast, and I really appreciate the opportunity to be on there, promoting coders and CDI and trying to change the outlook. Thank you so much.
I love it, Glenn. Thank you. I'll see you next time.
Yeah, thanks. Bye-bye.
And now it's time for my best practice tips in Trusty Tip. So in today's compliance tip, I wanted to dive into the new coding for home services, starting on claims for dates of service on January 1, 2023. Now, there's a concise description of those new changes in our MLN Matters number MM13004. And of course, those huge changes, revisions, and deletions have been made to our 2023 CPT coding manual in the red tab for evaluation and management services in pages 1 through 58 of our CPT coding manual. But specifically for today's Trusty Tip, I wanted to only go over pages 25 through 26 of the CPT code book. Now, this new section is titled Home or Resident Services. Now, remember, when you're looking at those new pages for the E&M section, of course, specifically on pages 25 through 26, you're going to be seeing a lot of green type, right? So the green type versus black means that there's new descriptions here that have been included by the AMA. So all of those code definitions, right, for the code selection have been revised, again, in the green, to require the appropriate level of medical decision-making, which are, of course, remember from our 2021 code rules that totally overhauled and were changed, right, from the 95 and 97 E&M guidelines. Everything has been overhauled to an MDM of straightforward, or an MDM of low, an MDM of moderate, or an MDM of high. And those are all defined in these new CPT code definitions, okay? So there is CPT code 99341 for the new patient, home, or residence services. which is going to equate to our straightforward medical decision making. And then there's also CPT code 99342, which is going to equate to our new patient with our MDM of low. And then there's also CPT code 99344, which is going to equate to our moderate medical decision making for the new patient. And then finally, there's also CPT code 99345, which is going to equate to the high MDM for the new patient in the home or resident services setting. And then we can move on to the established patient code, right, for the home or residence services setting. Now, there's a CPT code 99347, which is going to equate to that straightforward MDM. There's CPT code 99348, which equates to the low MDM. And then there's CPT code 99349, which equates to the moderate MDM for that established patient. And then finally, there's CPT code 99350, which equates to the high MDM for the established patient. Now, of course, our new E&M guidelines, right, like I stated earlier, for 2021 with revisions for 2023 include MDM or time, right? So we have to be mindful that you can choose MDM or time. So these codes also include time threshold definitions, as well as for total time on the date of service by the physician or other qualified healthcare professional. So the new guidelines, remember, also must have a medically appropriate history and physical examination. So time for that new patient CPT code 99341 must be documented as 15 minutes, must be met or exceeded. And then we can move on to CPT code 99342 for that new patient. There must be 30 minutes that must be met or exceeded. And then CPT code 99344 for that new patient, we must have 60 minutes that must be met or exceeded. And finally, for time for that new patient, for CPT code 99345, there must be 75 minutes that must be met or exceeded. And then we can move on to the time for the established patient, right? So that CPT code 99347, we must have documented 20 minutes of time being met or exceeded. And then for CPT code 99348, we must have 30 minutes that must be met or exceeded. And then for that established patient 99349, we must have 40 minutes that must be met or exceeded. And then finally, that established patient 99350, we must have 60 minutes that must be met or exceeded. So now our coding and billing staff must be aware that these services occur in these multiple settings: their home or their residence, right? Which includes an assisted living facility or a group home that isn't licensed as an intermediate care facility for individuals with intellectual disabilities, or a custodial care facility, or a residential substance abuse treatment facility. And again, coordinating with those locations are the place of service codes that go on the claim form as home, which is place of service 12, assisted living facility, which is place of service 13, group home, which is place of service 14, custodial care facility, which is place of service 33, residential substance abuse treatment facility, which is place of service 55. And finally, I focus Season 7 Spark on purpose and impact. I want this 7th season Spark to be filled with our world's thought leaders, writers, artists, philosophers, everyone who inspires the need for purpose and impact in all we strive to do. So, in this week's inspiring quote in Spark is from Leonardo Da Vinci. Make your work to be in keeping with your purpose. So very true, right? I think this is an amazing quote that reminds us that our work must align with our greater purpose. I think this quote reminds us that we all place tremendous value on our work and therefore our purpose. This quote inspires us to continue serving our overall purpose. I think this quote reminds us that we should embrace our inner light, that spark that burns within. I think this quote enables us to leave our own legacy of impact behind. I am happy Leonardo Da Vinci's spark still burns brightly in all of us today. So that wraps up today's episode. And as always, I appreciate you all diving into today with me. If you want more information from me, please go ahead and follow me on LinkedIn. I'll leave links to everything in the show notes below. Now, in my last thoughts today, it's that time of year, right? To start thinking about your intentions for the new year ahead. What is it you want? What is it that you're missing? What is it that you are seeking? I know I have so much I have yet to uncover and discover about myself in 2023. So remember, make your week ahead full of gratitude and take joy in every moment life has in store for you. Our lives are so very short, so make every moment count. Happy holidays, everyone. I hope Santa comes for one and all. Now, I hope everyone has the chance to give as well wherever they can. Thank you all so much for listening in on today's very special episode, and I hope every week with me brings you closer to helping your providers paint a masterpiece. See you next Wednesday.